stuff in conferences, it's just like, how do you even know what you want to do?
Right, exactly. And especially because of COVID, it's just become so hard for anyone to do any shadowing.
Yeah, of course.
We
Okay, give
just,
me one sec. I should be done
yep.
momentarily. All right. Stuff in conference.
Oops, my bad.
Share my screen. All right, are you able to see my screen?
Yep.
Play from start. All right,
Yeah.
you're in business.
But yeah, thank you so much for coming and letting us shadow you. This is it's
I'm
really
so
nice.
happy to do it. I love, like, you know, one of the biggest things for me was all of my mentors and people that I ran into when I was in like college and med school and all that. So any way that I can help people feel like they can do cardiology too and that it's fun, I'm happy to do it.
Right. I was actually so one of my aunts is a cardiology fellow. So
Ooh,
I just think it's really
awesome.
interesting. And I like when I like at least when I started like getting interested in medicine, I actually really wanted to be go into like cardio and like maybe like if I get a chance become like a cardiothoracic surgeon. It's a little like it's a stretch, but like still.
You know what? Cardiothoracic surgery is an awesome field. And if you want to talk to some female cardiac surgeons, let me know.
Really? That'd be
Mhm.
amazing. We don't get many surgeons like responding to us whenever we reach out because everyone's just so busy. So,
Yeah.
but that would be amazing if we could get like a
Yeah.
cardiac surgeon.
We'll be in touch after this thing, and I'll definitely like connect you with people that I know, because I think female cardiac surgeons and neurosurgeons are relatively rare, but they're out there.
Right. Yeah. Oh my God, that's actually amazing. Thank you so much for that.
Of course.
And you're actually one of the only cardio fellows that actually responded back to us. So that's actually amazing.
Oh,
We're
well,
like
I'm
really
glad to be
lucky to
here.
have you today.
Do you think we have a couple minutes?
Yeah. We can start in like 3 or 4 minutes.
Okay, perfect.
Yep.
I will be right back in just a second.
Okay, sounds good. All right, so we can go ahead and begin. So welcome everyone to today's shadowing session. Today we have Dr. Kothapalli with us, and she'll be speaking about cardiology. Thank you so much for being here with us.
I'm so happy to be here. My name is Priya. I'm a PGY5 cardiology fellow at UT Austensville Medical School. The reason I'm here is because this is an amazing program, and I wish I had stuff like this when I was in medical school. And on top of that, I think that COVID has kind of created all these unique challenges. So this is an awesome way for people to kind of explore different specialties, I had a lot of benefit from meeting people that I could relate to, that I enjoyed being around, that mentored me whenever I was in college, medical school, and beyond. And so, in a way, I think it's so important to expose others that are behind you in training to different things and see what people like and really kind of lay the foundation for people to progress. And so, I'm happy to be here today. Thank you for having me.
Yep.
Cool. Should we get started?
Yep. You can go ahead and get started. Yep.
All right. So welcome to Cardiology Fellowship, first and foremost. It is a fun 3 years of your life and very worthwhile, a really cool opportunity to see a ton of stuff. The next slide I'm going to show you is a little bit non-traditional. This is a slide that was shown to me by my mentor in General Cardiology Fellowship, who is the program director of our Interventional Cardiology Fellowship, where you go through all these steps of training and you kind of feel lost after a certain point. There's so much out there. And, whenever you feel like you finally made it, there's so many different choices on what you can possibly do with your life. And so I think really important to keep an open mind, to realize that, the world is really your oyster, and don't limit yourself, regardless of, what your goals are down the line. Keep an open mind for everything. So to start, I actually did an Instagram takeover for Dell Medical School, with kind of like what is an average day in the life of a cardiology fellow like. And so I'm going to play that here for you guys. This was a lot more fun on Instagram because it had all the tunes, but just kind of going through this video, you can see that we have a number of different locations where we do rotations. In any given day, we could be in the cardiac cath lab, in the echo lab, doing ultrasounds of the heart, electrophysiology, doing procedures that are related to the conduction system, or on a consultative service or in the ICU. And so there's an incredible diversity of your exposure whenever you're a cardiology fellow. And just to kind of, this was part of that IGTV takeover, but what I wanted to show you guys is, whenever I'm in the hospital, this is what my day looks like. At 6:30 in the morning, I'm usually prepping for cases in pre-op. This is whenever I'm on the cath lab rotation, meaning I'm doing procedures like right and left heart catheterizations, heart valve replacements, peripheral interventions. So so kind of this rotation where you get patients ready early in the morning and you do cases throughout the day. And so here, this is a lead apron that we wear to protect ourselves from radiation exposure, super important. But I'm taking my lead up to the hybrid operating room where we do transcatheter aortic valve replacements. We usually on our valve clinic days have clinic at 7:30 in the morning where we sit down with our entire team, interventional cardiologists, imaging cardiologists, cardiac surgery, everybody, and really talk about the best way to approach each procedure for a heart valve replacement. I think that the multidisciplinary aspect of cardiology is something that's super awesome, and you learn a lot about different specialties. You learn a lot of unique perspectives, and it really is a really cool collaborative effort. So this is kind of a cool demo valve of what we actually insert into the body. So previously, patients didn't really have many minimally invasive options for aortic valve replacement. With the advent of transcatheter therapies, we're getting better and better at doing transcatheter aortic valve replacements. And here is an example of a TAVR valve here. At the same time, my good friend and colleague here is kind of leading the consultation service at the medical school. My other colleague is doing electrophysiology, and here we are in the cath lab doing procedures. And the video kind of continues on to give you a little bit more perspective on what we do. And so it's actually a really unique opportunity to be immersed in a number of different environments throughout the day and really see a lot of interesting things. And of course, it's lifelong learning. I used to take notes like this in medical school. I still take notes like this in cardiology fellowship. And this specifically is, pictures that I've drawn for TEE, which is transesophageal echo, and transeptal puncture and mitral valve replacements, all things that you kind of, learn about as you progress over time and develop your own interests. And so with that being said, I wanted to tell you guys a little bit about what a day in the life really is like for us. So day to day, we do a number of different rotations. Each one is structured about a month long in general cardiology fellowship. We spend several months in the cath lab where we do these procedures. The cath lab is where patients go whenever they come in with heart attacks, which is probably the most well-known cath procedure for most people. We spent several months doing echocardiograms, kind of a window into the heart, both surface echocardiogram, meaning putting an ultrasound probe down on the chest wall, and transesophageal echocardiograms, where you actually put an echo probe into the esophagus to look at the heart from the back forward. And so you're looking at the heart structures through the left atrium, which is the posterior most structure of the heart. We spend time in the ICU, we spend time doing nuclear stress tests, consults, advanced heart failure, adult congenital, advanced imaging like cardiac CT and MRI, and of course, longitudinal clinic where we really do learn how to practice bread and butter cardiology. In terms of commitments for hours, it's pretty variable. There's some rotations that are more demanding. For instance, cath lab, we spend like 6:30 in the morning until maybe 5 or 6 p.m., barring any emergencies that potentially could go longer. Echo and other imaging rotations tend to be pretty standard. We spend from 8 a.m. to 5 p.m. ICU is another very demanding rotation. Again, days last anywhere from 7 a.m. to 5 or 6 p.m., sometimes longer, depending on the clinical needs, and so on and so forth. But pretty representative of what my fellowship structure has been to date. And of course, we do overnight calls. Really, that's when I feel like I've learned the most, whenever I'm there by myself, trying to figure out what the right thing to do is. And, always have your backup support, but whenever you're the person making the decisions, you really take ownership of that, and I think really grow as a physician. So why cardiology? I wanted to refer you guys to one of my favorite podcasts, which is the Cardio Nerds. They have an amazing series of short clips of why different people chose cardiology. And every answer is so unique and interesting. And I love kind of learning why other people chose this area of expertise. What I love about cardiology personally, just to give you a little bit of background, I grew up around cardiology. My dad is an interventional cardiologist. I went to the cath lab with him as a child, had a fascination with it. I thought I wanted to be a physician whenever I graduated from high school. Did a 7-year medical program and ended up loving the anatomy, cardiac physiology that I learned during some of my basic courses. I found a mentor at the medical school who really helped me to, one, shape my interests and also kind of get my foot in the door in terms of research opportunities and networking and meeting people. And, one thing led to another. And, through the support of some really awesome people and some really unique opportunities, I'm here today, general cardiology fellow and future interventional fellow. So I think, that is kind of what got me interested in cardiology. But now what I love about the actual science is the physiology, the pathophysiology, the fact that the decisions that we make are so data driven, and we have all this technology that's evolving so rapidly over a very short period of time. And it really does kind of create this challenge where you really want to keep up with the literature, you want to keep up with the current practices and guidelines, and you want to keep evolving as a physician. And I think that's very exciting. The other exciting part of it is the high acuity patients that you can see, and definitely there is a huge need for more diversity within the field of cardiology. I've had female patients tell me, I'm so glad to see a woman standing at the table, and it gives me so much relief that my doctor is somebody I can relate to. And I think that definitely does play a role in my aspirations, and kind of gives me the passion to keep pushing things forward. Some of the very granular things that I'm interested in are vulnerable plaque, intravascular imaging, and coronary physiology. And all of these interests kind of developed as I exposed myself to more cardiology. I went to grand rounds, I met people, I went to journal clubs that were cardiology focused, even as a medical student and internal medicine resident, and ultimately learned a lot over a long period of time. So these interests have really kind of started over a period of 10 years and kind of nurtured them as I progressed in my career. So just to give you guys a little bit of background, cardiology is a relatively young field when it comes to intervention. The first right heart cath was performed in the 1920s when Dr. Forsman actually performed it on himself. As technology and time has taken us forward, we are now in the 2000s where we're in the era of precision coronary intervention. And I think that's so exciting. There's so much technology, there's so much data, there's so much information, and you have a patient in front of you and you're making real-time decisions. And it's a really exciting field. I think that it's definitely an area, one of the most rapidly growing areas in medicine as well. So I wanted to start with a case, and I don't know if we have people on here for me to call on or if anybody wants to answer. But here is a case of a 55-year-old man with chest pain. And my question is, what would you want to know about this patient? And so when we talk about chest pain, we want to know a number of different things. So first and foremost, 55-year-old man, we want to know what kind of past medical history he has. He has no prior medical history that we know of, and he presented to the emergency department with a complaint of chest pain that's anterior substernal, pressure-like, non-radiating, 10 out of 10, that started while he was lifting heavy boxes. The pain continued on even despite rest, and so he called EMS to come and evaluate him. No significant past medical history, as we discussed, just going through this kind of format that we use routinely in the hospital. Past surgical history, non-contributory, just had a total knee replacement several years ago. Family history of myocardial infarction, meaning heart attack in his father at age 51 and grandfather at age 58. And social history of former smoker, smoked a pack a day for about 10 years, but quit 10 years ago, and no other alcohol or illicit substance use history. All these things are important because as we're evaluating this patient, we want to kind of think, what is this patient's risk for having a heart attack? And we also want to keep our differential broad, and we want to make sure that we don't have tunnel vision whenever we're evaluating these patients with other considerations like aortic dissection, pulmonary embolism, any kind of acute life-threatening process. And so continuing on with his case, the physical exam is extremely important. It'll give you a lot of information about how quickly you need to move on this patient. So the patient was afebrile, heart rate was 104, which is elevated, so tachycardic. Blood pressure was 210 over 130, so extremely high. Respiratory rate was 12, O2 sat was 95% on 4 liters of nasal cannula, and the patient's BMI was 32. The exam was really remarkable for patient in mild distress due to pain. He was clutching his chest and saying, "My chest hurts," and it's 10 out of 10, and nothing gives me relief. And he was diaphoretic or sweaty. And respiratory exam, he did have some scattered rails. And his cardiovascular exam, tachycardic with regular rate or regular rhythm, excuse me, with a normal S1 and S2 without any murmurs, rubs, or gallops. His abdomen was soft, non-tender, non-distended, and he didn't have any lower extremity edema, and he was warm and dry, so well perfused. So what test would you guys want to get next on this kind of patient? So here we have an electrocardiogram, and the important question is, is this something that you would call an emergency, call what we call a code STEMI, and meaning an ST elevation myocardial infarction? And so whenever we look at this EKG, we want to see, of course, all the basics, so rate, rhythm, axis, intervals, but we also want to look at the ST segments. And looking here, we want to see if there's any ischemic injury pattern that would suggest a coronary territory. And so looking at this EKG here, we do see these tombstone ST elevations in lead 3 and AVF, in addition to V1 through V3. So this is suggestive of anteroseptal, anterior, and possibly inferior ischemia. So immediately you start to wonder, is this a blocked coronary artery? And looking at the patient's labs, which we did not have at the time of this, so EMS did activate very appropriately a STEMI, and so this patient was rushed to the hospital. They were brought immediately into the cath lab, actually, without even stopping in the emergency department for emergent cardiac catheterization, because they suspected that he had a blocked artery, and time in this situation means muscle. And so as the patient was getting loaded on the cath lab table, we got some extra data back where he had blood drawn and sent at the outside freestanding ER, where hemoglobin was normal, platelet count was normal, coags were normal, which is important as we're preparing for a procedure. His kidney function is normal with creatinine of 0.7, which is important for us to consider because we will be giving him iodinated contrast. His blood glucose was in the 400s. His initial troponin was negative and his BNP was within normal limits. Reevaluating this patient's symptoms, he continued to have 10 out of 10 chest pain, mildly improved with sublingual nitroglycerin. So the question at this point is, what would you do next? Do you think that this patient is appropriate for an emergent left heart catheterization? And I'm presenting this case from, actually, it's from a couple of nights ago. And so the answer is yes, this patient is very appropriate to go to the cath lab. And so we did take him to the cath lab. This patient, we can see here, this is one of our angiographic images. This is a left ventriculogram where we inject contrast through a pigtail catheter into the left ventricle. And you can see the heart squeeze function. So normal LV ejection fraction, meaning how much blood the heart squeezes out with every cardiac cycle, is between 60 to 65%. And we also look at wall motion. And so here, it's hard to appreciate on this image, but you can see that this part of the heart, which we call the anterior wall and the apex, are not moving as well as the bottom part of the heart or the inferior wall. And we can tell that the ejection fraction is probably reduced. And so already we're getting a sense of where the blockage might be. And the important thing to remember about coronary angiography is that you're getting a 2D image of a 3D structure. And so we always do imaging in orthogonal views to really get a good sense of what the vessel actually looks like. Sometimes in a single view, you may miss lesions, and other times you may misinterpret tortuosity for a lesion. And so really important to get orthogonal views. But right off the bat in this projection, we would normally see, this is the left main coronary artery, the left circumflex coronary artery, and normally we would see the left anterior descending artery coming here, and we can see that it's abruptly cut off here and it's got a hazy appearance. So we have confirmed our suspicion that this patient is having a heart attack involving the left anterior descending artery. And just for the sake of completeness, I'm going to show you the right coronary artery, which is free of significant disease. There's mild mid-vessel disease, but nothing that would explain his current presentation. And so in this situation, we proceed with what we call percutaneous coronary intervention. We basically use a guide catheter, which is a hollow plastic tube, to engage the ostium of the left main coronary artery. And we then place a coronary wire into the vessel. It's an 0.14-inch coronary wire. And we use that wire as a rail to deliver a number of different types of equipment. And so this is where, if you've heard of the concept of door to balloon time, this is what we're talking about. How long does it take you to restore blood flow into that vessel? And so here is another view that kind of gives you a sense of where the LAD should be here. And this is the iliocranial projection here. And here is a wire down, and this is actually after we've already delivered balloon, coronary stents, and are post-dilating, meaning that we're trying to fully expand the stent to size. And this is our final angiogram. So whereas in this initial picture, we didn't see any blood flow to this huge part of the anterior wall here, now we've been able to restore what we call brisk TIMI3 flow into the distal vessel. And this patient's chest pain symptoms actually resolved. The importance of this is that time really is muscle. And so whenever we're talking about a heart attack, we really want to get the patient in for revascularization as quickly as possible, because the patient is having active myocardial cell death, and that can result in a number of complications, arrhythmias, mechanical complications, cardiac cardiomyopathies, heart failure, and death. And so the faster you can get the patient in, the better it is for the patient's long-term prognosis and survival. Here, just to highlight, the EKG changes that you start to see with ischemic injury. You have this continuum of ST changes that you start to see with EKG, as well as T wave changes. And just to kind of touch briefly on some of the bad things that can happen if we don't fix the culprit lesion in a timely fashion, you can have free wall rupture, ventricular septal rupture, papillary muscle rupture, severe mitral regurgitation due to the blood supply to the papillary muscle being compromised, LV aneurysm. So there are a number of really serious complications that can happen that can be potentially avoided now that we have the technology to perform this life-saving intervention. And it's a really cool opportunity as a general cardiology fellow and future interventional fellow to see kind of the direct effect that your procedure has on somebody's long-term well-being. So back to our patient. The patient's chest pain resolved after we did his percutaneous coronary intervention. He was put on appropriate medical therapy, which after a drug-eluting stent, we always put our patients on dual antiplatelet therapy, in this case, aspirin and prasugrel in the setting of an acute MI. High-intensity statin with LDL goal of less than 70, beta blocker and spironolactone. For his transthoracic echocardiogram was performed to give us an accurate quantification of his LV ejection fraction, which came back at 40%. And he did have what we call hypokinesis, so reduced movement of the anterior and apical walls, which are supplied by the left anterior descending artery. And we're hoping that over time he will recover some of that in the setting of possible myocardial stunning in the setting of an acute MI. For medical optimization as an outpatient, this is probably the most important part of this whole thing. Preventing heart attacks and preventing future heart attacks is so incredibly important. And I can't emphasize enough how much it means to reduce blood pressure, improve blood glucose control, reduce LDL, reduce inflammation, and change people's lifestyles. And also cardiac rehab is an extremely important part of post heart attack recovery. So any questions at this point, or should I keep going? So I'll keep moving along. So the next case that we have is a little bit shorter, but just to kind of highlight some of the other really interesting and cool multimodality tools that we have. We had a 59-year-old man that presented to our teaching hospital with the complaint of dizziness and shortness of breath. He's a 59-year-old with past medical history of stage 4 lung cancer, who came in with the shortness of breath and dizziness that started about a week or two ago. His CT scan that was performed for his cancer staging a week before his admission actually showed a large pericardial effusion in addition to other findings that are not relevant for our case. And the patient was actually being evaluated in the emergency department when he was noted to have a heart rate of 120 beats per minute with blood pressures that were initially in the 100 millimeter mercury range for his systolic pressures, but gradually started downtrending to 80 millimeters of mercury. And so a stat echocardiogram was ordered, and cardiology was emergently consulted to the emergency room. Patient's past medical history other than stage 4 lung cancer was hypertension and type 2 diabetes. He had no prior surgical history that was relevant, no allergies, and medications. Important to note, he's on amlodipine, lisinopril, hydrochlorothiazide, and metformin. And so labs here, he had an acute kidney injury with creatinine of 2.2, B1 of 58. His coags were, INR of 2.3 was elevated, platelet count was slightly lower at 130, with some anemia that was likely chronic anemia due to, anemia of chronic disease. I unfortunately don't have the video of our patient here, but what we did see was that what we can do very quickly is do a few echocardiographic views to determine if somebody has echo findings that are consistent with what we call cardiac tamponade. And so here we see that the heart is here. This is a subcostal view. We're looking at from underneath the ribs, and the heart is here. And this is all fluid surrounding the heart. And this I kind of adapted from the internet, but very similar classic finding of big pericardial effusion with compression of what we call the right ventricle here. So the anterior most chamber of the heart, the right ventricle, the LV, the thick walled muscle that pumps blood out of the heart into the body. And so we were looking at for a number of different echocardiographic features, which I'll briefly mention, but really cardiac tamponade is a clinical diagnosis, and the ED very appropriately ordered this echocardiogram. These patients present with hypotension, JVD, muffled heart sounds, pulsus paradoxus, which is actually a very interesting finding. It's a greater than 10 millimeter mercury inspiratory difference in systolic blood pressure, and it's highly sensitive to find cardiac tamponade. Negative Kussmaul sign, loss of Y descent, also important features. And then echo features that are consistent with tamponade are things that we look for as cardiology. So we look for early diastolic RV collapse. So the RV normally contracts during systole, so we expect the RV to contract. In diastole, the RV should actually be filling. And so if we see that in diastole, the RV is collapsing, that is a feature that's suggestive of tamponade. But again, tamponade is a clinical diagnosis. We also see what we call respiratory variation of the mitral and tricuspid inflows. These are the percentage cutoffs that we use. IVC plethora, meaning that IVC is dilated and there's no respiratory variation. And then late diastolic to early systolic atrial collapse. These are 4 features that we look for tamponade physiology on echo. So how do we treat these patients? The only way to treat these patients really is for us to do an emergent pericardiocentesis, so relieve the pressure around the heart. And so in order to do that, we can do that with ultrasound guidance, which is what we use to acquire these images, or we can use fluoroscopy or both as adjunctive therapies. And my preference really is to use both technologies, primarily for safety and to give us more visualization of the structures. So we take a needle, and you can perform this in a number of different ways, but take a needle, subxiphoid, and you basically aim for the left shoulder blade or mid-clavicle, and you are aspirating negatively until you get some fluid back, and then you confirm your position with a number of different techniques, including placing a wire into the pericardial space. Some people actually do what we call like a bubble study, where you inject agitated saline into the pericardial space and confirm on echo that you're in the correct location. You can also check pressures to see if you have a waveform that's suggestive of the right ventricle or the pulmonary artery, or if you have a very flat waveform that looks like an intrapericardial pressure. And so back to our patient, we were able to successfully perform a pericardiocentesis. We took out 2 liters of serosanguinous fluid, which was sent for analysis and came back as a malignant effusion, unfortunately. But in this situation, our patient's hemodynamics improved rapidly, and it's pretty impressive how quickly patients get better once you do their pericardiocentesis in the absence of certain specific conditions like aortic rupture, or there are kind of a handful of things where you would not want to do a pericardiocentesis. But in this case, the patient actually did incredibly well. Heart rate very quickly came down from the 120s to the 70s. Blood pressure very quickly rose from 70 to 80 systolic up to 120, 130, and the patient was discharged home with a modified antihypertensive regimen and actually taken off of diuretics. Cardiac tamponade is profoundly preload sensitive, so those patients do better with more volume. And so that kind of concludes our cases. And so I wanted to see at this point if anybody has any questions. And if not, I'm just going to share a couple of my little, I'm sorry?
Sorry. You can find the questions in the chat. If you go in the chat, there's all the questions that they have put in, and you can go through them if you'd like.
Yeah, do you guys mind sharing them with me? Because whenever I'm screen sharing here, I don't think I can look at my chat box.
I'm not
So let
really
me see if I
sure
can.
how
Oh, here we go.
to.
Awesome. So just to go through some of these questions. So one of my questions is, who do you mainly work with, and what are some of the most common technologies you use when diagnosing patients? So, we mainly work in terms of like physicians that we work with literally everybody, everyone from family medicine to internal medicine to emergency, cardiac surgery, vascular surgery. We pretty much work with every person that you can imagine. I think cardiology is an integral part of a lot of different multidisciplinary discussions. And so we do tend to have a very wide network that we interact with on a daily basis. And then the second question is, what are some of the most common technologies you use when diagnosing patients? Hands down, cardiac echocardiography is one of our most essential tools. It's giving you literally a window into the heart. That being said, we also have invasive hemodynamics. You can gain a lot of actually non-invasive hemodynamics from echocardiography. And going back to other tools, right heart catheterization, where you're floating a catheter that can measure the pressures inside each cardiac chamber to help you quantify somebody's volume status, somebody's pulmonary vascular resistance, somebody's cardiac output, systemic vascular resistance. All these things are hard data and numbers that you can use to make clinical decisions. And then of course left heart catheterizations, where you're injecting contrast into the coronary arteries to look for blockages or obstructions to flow that would cause ischemia to the heart muscle. And so there are so many different tools that we use on a daily basis, and electrophysiology has their own set. It's a very, very broad range of rapidly evolving technology as well. And then my next question, what are some common complications that cardiologists may run into while performing procedures? So I was once told by my mentors, if you don't have complications, you haven't done enough procedures. And unfortunately, it is true. Though, these procedures are extremely safe, and we tend to be very conscientious of patient selection and also of our technique, inevitably, we're going to run into some complications. Access site complications probably tend to be the most common ones that we see. The way that we enter the artery or vein that we're using is a channel into the heart. Sometimes you can have hematomas, you can have dissections, bleeding, infection, very rarely pseudoaneurysm, retroperitoneal hematoma. These are all things that can happen even with just a simple, puncture of the artery whenever you're doing cases. You can have also, whenever you take catheters up to the heart, you can always cause damage to any of the vascular structures or that you're interacting with. And so coronary dissection is one of our most feared complications, because your patients can become unstable and require percutaneous coronary intervention. And those patients are actually very hard to treat. The other ones are conduction abnormalities from basically tapping on the septum where the conduction system lives. You can put patients into heart block, even doing something as simple as a right heart cath. And though all these really scary things can happen, they're extremely uncommon. And we're very prepared to handle the complications that can occur. And going back to actually our last case, one of the more serious complications that can happen is whenever you're performing a pericardiocentesis. If you think about the anatomy of the heart, the anterior-most structure in the heart is right ventricle. And so whenever you're introducing a needle, you can actually puncture or lacerate the right ventricle. And so usually, unless you put a larger pigtail catheter up, it doesn't have much of a consequence. But if you do run into a situation where you've put in a pigtail catheter into the right ventricle, that's actually considered a surgical emergency. And so we work very closely with our cardiac surgery and vascular surgery colleagues, because these complications are inevitable, but thankfully I've seen very few of them so far. But again, that means that I haven't done enough cases likely. And let's see. So one of the questions I got is, how are the paths to becoming an invasive and non-invasive cardiologist different? And, it's actually the same general cardiology fellowship that you do for 3 years as anybody. So you're not really differentiated in those first 3 years. People that are going into invasive cardiology tend to want hands-on experience, but I've actually been told by my mentors that it's super important to get a really comprehensive training whenever you're doing general fellowship. So learning the imaging that you'll likely never spend so much time thinking about again, because all of our worlds kind of collide. For a lot of structural interventions, we rely heavily on the use of transesophageal echo, transthoracic echo, even intracardiac echo. So looking at the heart from the surface, from inside the esophagus, and even from within the heart. And understanding what the heart looks like in three-dimensional space while manipulating catheters in 2D images is actually absolutely essential as cardiology does more and more structural heart work. And so the paths are pretty similar until that divergence where you decide I'm going to be an interventional cardiologist or electrophysiologist, which are invasive specialties, or advanced cardiac imaging, advanced heart failure and transplant, cardiac critical care. And so at that point, your training becomes much more differentiated. But for the most part, general cardiology is pretty well-rounded. All right, let's see. And oh, I love this question. What are techniques that you use to ensure effective communication with other professionals needed in certain cases? And I think, the communication part of it is so important. And I don't think that we have that emphasized enough in medical school or even in residency, how important it is to learn how to speak with others, whether it's nursing or respiratory therapy, cath lab technologists, other physicians, because a lot of what we do is communicating with others, trying to get things done, trying to make the right decision, trying to communicate our thought process. And so I think it's really important to learn how to very respectfully express opinions, even if they're different from others. It's kind of an art, if anything, that really, I think, being considerate of what other people have to say, presenting your thought process in a non-threatening and non-judgmental way, and really backing your logic with facts. So methodically explaining why you got from point A to point B and why you think a certain decision should be made. It takes practice, but it's extremely valuable in the setting. So the next question I have is, how has COVID-19 affected your work? And what is it like to work in your field of medicine? So I think everybody's been affected by COVID for a variety of different reasons. I think personally and professionally, we did actually a lot of extra ICU coverage for some time whenever the COVID numbers were peaking, but really providing a lot of cardiology care. We saw a lot of cardiomyopathies with these patients, conduction disease with these patients, pericardial effusions, acute coronary syndromes, the full spectrum of cardiovascular disease. And so, performing, procedures was a little bit limited because of, the need for shutting down elective procedures, but we saw a very different spectrum of patients. And thankfully, we've returned more to a normal at this point from our standpoint here. And then the next question I got, what are your favorite procedures to do and why did you want to do a fellowship? So my favorite procedure is actually, this is very nerdy, but invasive hemodynamics. It's whenever you use catheters to measure pressures within the heart, and you can perform a variety of different calculations to understand the physiology within the heart. I just think it's a lost art. And my mentor and the chief of cardiology at Dell Medical School was actually involved in some of the work for some of the equations that we actually use in the cath lab for shunt calculations. And so I think, there's so much information that you can get from doing a heart cath. It's not just taking pictures, but it's also understanding physiology, and that can really affect how we treat patients. And I think that it's just a really cool opportunity to learn more about somebody when you're doing an invasive procedure. And what's the next question here? A lot of these questions are about COVID. I'm sure everybody's had their fair share of COVID-related difficulties. Oh, this is an interesting question. Why did you choose a non-surgical specialization? Why did you not go into cardiac surgery or cardiothoracic surgery? I think every person I've talked to that is in interventional cardiology has this very surgical mentality about procedures. We really treat it as if it is an art form that we are perfecting in addition to a science where we are challenged every day with new clinical problems and new technology. I think that cardiac surgery and interventional cardiology, while they do have some overlap, there is a lot of unique things that come with doing interventional cardiology. For me, I was always interested in internal medicine. I liked to think about problems. I like to solve problems. It's kind of like putting together the pieces of a puzzle in a way that makes sense. And for me, that was internal medicine. I wasn't really drawn to surgery and training. Then as I progressed in cardiology, I realized that I love doing procedures. I love the hands-on aspect. I love the therapeutic part of dealing with a patient in cardiogenic shock and putting in mechanical circulatory support, or revascularizing a patient who's having a heart attack, replacing a heart valve with minimally invasive techniques, going in through arterial access in the leg to deliver a heart valve that essentially sits in the place of the old heart valve, which is still there. And avoiding things like sternotomy, so big incisions in the midline of the chest, and going through major, very invasive procedures. And as I developed more interest in cardiology, I also started to really appreciate the concept of vulnerable plaque. These patients who come in with heart attacks don't always have these 80–90% blockages in the heart arteries. And oftentimes we see patients that don't really have much of anything on angiography, meaning that their vessels don't look like they have any significant flow limiting blockages, but they still have heart attacks. And understanding why this happens to people is one of my personal passions. And this is actually possible partially with intravascular imaging, where we can actually look at the inside of the blood vessel in these patients and see what the mechanism for their plaque rupture is. And so the concept of vulnerable plaque and intravascular imaging and precision PCI really appeals to me, and is really my area of passion and interest, because the treatment isn't just putting in stents and treating people for heart attacks. It's actually preventing them from having heart attacks by stabilizing the plaque that exists in these patients and reducing the plaque burden. And so I think interventional cardiology is a very different field from cardiac surgery, though there is some overlap, especially in the structural space. And then before we run out of time, I'm just going to kind of finish up going through my slides here. So just some things that I wanted to emphasize, and none of these are like really scientific points or anything, but these are things that I wish I knew whenever I was in medical school or in college, or even in residency. And number one is prioritize your own well-being. It's so important to do the things that make you feel like you. Sleep, exercise, whatever it is that makes you feel whole. It's so important to keep doing those things. And I had so many times in medical school where I was scared to step away from my books, even for 30 minutes, because I thought, oh, I'm going to miss something that I really need to know. But at the end of the day, it's so important to take care of yourself before you take care of anything else in your life. I think prioritizing yourself will make you a better physician. The second thing that I wanted to emphasize is, if you find somebody that does something you're interested in, reach out to them. 9 times out of 10, people are going to say, absolutely, I'm so flattered that you reached out, or how can I help you? I would love to help guide you in your career. And really don't hesitate to talk to people. I think I was actually very scared to reach out to people initially, and I realized more and more as I progressed that people actually love it when you ask them about what they do. And most of the time, they're very interested and eager to help you find your own path as well. And that being said, knowledge is cumulative. Just because you're in college doesn't mean that you can't go shadow an interventional cardiologist. You build layers of knowledge. Just because you don't understand what a drug-eluting stent means, it doesn't mean that you're not going to gain any value from going and seeing a percutaneous coronary intervention. So really, really important to immerse yourself in anything that you find interesting and just take it all in. Don't pressure yourself to know everything on day one, because it really is a marathon. It's a long process, and the expertise builds gradually over time. And don't be intimidated to express interest in something if you do find it appealing to you in any way. And then my other recommendation, this is mainly for people that are already in medical school or residency. If you know what you want to do, just start early. I think it's important to connect with the right people, start research, go to conferences, meet people. And again, knowledge is cumulative. And so, of course, research is one of those things that you either really love to participate in the scientific inquiry, or it's kind of a means to another stage in your career. But again, anything you learn in that process is incredibly valuable as you move forward. The other super important thing, other life hack, is surround yourself with people that are going to encourage you to be the best version of yourself, and actually encourage you to pursue what you want to pursue. Super, super important, because you're going to have days where life is hard, work is hard, high stress, high demand. Not everything will go right, even if you do everything right. And so having people on your side that are going to tell you that it's okay and that you should keep going if that's what you want is super important whenever you need that extra support. And even just day to day, it's fun to be able to tell people what makes you excited without feeling judged, or without feeling like you're going to be told that it's the wrong thing to do. So positive people, positive energy. I think that's so important. And then sky's the limit. Don't limit your potential for growth, and always have that growth mindset and stay true to yourself. I really think that one of my goals in doing this talk is to show you that you can be different from the traditional mold of what a cardiology fellow is, what an interventional cardiology fellow is, and still be very successful. And I think that's true for any other specialty where there's a significant discrepancy in any kind of background. So whether it be gender, ethnic backgrounds, socioeconomic backgrounds, I think that the diversity is so, so important for a brighter future in medicine. And so I really encourage you to not limit yourself, stay true to yourself, and just keep growing. And it's super important. All right, I think we already did most of this Q&A, but unless you guys have anything else.
Thank you so much for talking to us.
I'm happy to talk to you guys. And this is my dog, Lub Dub, like the heart sounds.
You have a really cute dog.
Thank you.
So thank you so much. I think we got all of the questions. I think you answered most of them anyway. So if you have anything else, I think we're about to wrap up now.
Awesome. No, that's perfect.
All right. Thank you so much. Have a good night.
Thank you. Bye.
You too. Bye.